Okay, all right, that sounds good. It's hard to tell if everybody's in the room.
From Rafael is
Bienvenidos. Bienvenidos, mis amigos, a esta sesión primera de Latinoamérica aquí, en this meeting. Thank you very much. I'd like to welcome everybody to this first Latin American session at our annual meeting on endocrine surgery in Latin America. I'm going to talk for just a moment about the concept behind this effort, and this is very similar to what we went through last night, and then I'll introduce our co-chairs. We created, Carmen and I, the Pan American Task Force this year as part of one of the initiatives, one of the strategies to engage all of the Americas, all the surgeons across the Americas for endocrine surgery. Our co-chairs, Denise Carniero-Pla and David Velasquez-Fernandez, then put together a work group, and you can see on this map of North and South America where the members of the work group reside. And we felt that this was really an excellent representation, a truly Pan-American representation for this work group. Now, I have to tell you, I have heard recently that Denise is being bombarded with more and more people who want to join this work group. Good for you. Self-nominate, let the co-chairs know that you were interested and engaged in this topic, and we will build this work group and make it even better, make it easier for them to do the things that they want to do. Speaking of what they wanted to do, as I mentioned last night, we started out this process. It was actually Dr. Fahey who initiated this concept during the last presidency. I didn't come up with any original ideas or anything like that. I just asked Tom for permission to take the ball and run with it. And we started by reaching out to our sister organizations across the Americas. And then we got some responses, and we sent some of our AAS leaders to other meetings in Central and South America. We then invited leaders from these sister organizations to attend and participate in our meeting. I think you've seen today and yesterday distinguished moderators and panelists that are representative of the Americas, and then also course instructors, and now this first Latin American session here in Birmingham. So without any further ado, I'd like to introduce the co-moderators for this session, Denise Carniero-Pla and David Velasquez-Fernandez.
Well, Denise and I, we would like to thank Dr. Surgeon for the privilege to have this very first session. So we will be very happy to present 3 clinical scenarios. For time reasons, for time restrictions, we won't take any questions from the audience till the end of the session. And our main goal of this session is basically to show some of the differences as well as convergences from our clinical practice endocrine surgery throughout Latin America. So for that, we have 3 clinical scenarios. The first one should be deal about a adrenal case that will be presented by Dr. Rafael Perez-Soto. He's adjunct professor of endocrine surgery at the National Institute of Mexico City. And the famous discussant is our privilege to have the coming president, Dr. Carmen Solórzano from Vanderbilt University and Medical Center. The second case, well, Dr. Rafael, please.
So good afternoon, everyone. Thanks for the kind introduction. I just want to take some time to thank the AAS for the opportunity to present this case the day of today. I have no financial disclosures. I must say that I'm an endocrine surgeon that was trained and is practicing in Mexico. And the case is about a 50-year-old man known in our hospital due to a past history of complicated acute pancreatitis with a pancreatic pseudocyst that was surgically treated 20 years ago with a cystojejunostomy. 4 years later, the patient developed type 2 diabetes with no acute complications documented at the moment of the outpatient clinic, with documented incipient diabetic nephropathy to say about, for his last albumin levels in the 24-hour urine analysis. Current treatment was based on insulin, metformin, and empagliflozin. So we saw this patient in the outpatient clinic of endocrine surgery due to a long-standing right cervical mass that had grew in the past few weeks, enough to make the patient to seek for evaluation. The patient was euthyroid at the moment, and the ultrasound showed 2x2 right thyroid nodule suspicious for malignancy and metastatic lymph nodes in the central and right cervical compartments. So an FNA was performed, and the nodule came out as a mixed diagnosis of a papillary thyroid carcinoma and an anaplastic thyroid carcinoma. Due to this last diagnosis, FDG PET-CT was performed without distant metastasis identified at that moment. So we took the case to the multidisciplinary tumor board for discussion, and the plan was to take the patient to the OR with a surgical plan of doing a total thyroidectomy with central and right lateral neck dissection that was performed. During the procedure, we identified involvement of the right recurrent laryngeal nerve. So the nerve was resected in block to achieve an R0 resection. And despite of this, the patient was discharged uneventfully on postoperative day 5. So unfortunately for the patient, came again to the hospital, to the emergency room in postoperative day 12 with a chief complaint of severe and diffuse abdominal pain with associated nausea and vomiting. So vital signs were stable at admission. Lab work didn't show nothing really concerning. And due to the severity of the pain, the patient was taken for a CAT scan. The CAT scan you can see on the video on the slide, in which a non-active bleeding of the left adrenal gland was identified. So the patient was admitted to the hospital for close surveillance, IV fluids therapy, and pain medication. During follow-up, at 48 hours, the patient changed drastically, showing an increase in abdominal pain intensity associated with diaphoresis and pallor skin. It started to get tachycardic, tachypneic, and a slight change in BP regarding previous measurements. In the lab work, we identify a hemoglobin level drop of 3.5 grams. So at that moment, high volume IV infusion was started. Packed red blood cells were crossed and requested for the patient. And in the meanwhile, the patient was taken for another CT scan for an image control. So in the new in the new IV contrast CT scan, display an increase of the hematoma size, volume, and an evident leak of the IV contrast into the hematoma, suggesting an active bleeding. The patient were thereafter taken to the interventional radiology department for an angiogram and probable embolization. During the angiogram, an active bleeding from a branch of the inferior adrenal artery was identified, and embolization was performed by means of microspheres, cyanocrylate, and lipiodol, which stopped the active bleeding at that moment. The patient was already transfused at that moment with 3 packed red blood cells and came out of the procedure stable. So sadly, 12 hours after this procedure, the patient again started to be tachycardic, and another drop on hemoglobin levels was identified. So by that moment, the multidisciplinary team was discussing about taking the patient again to a second attempt and possible second embolization, or to take the patient for emergency surgery. During this discussion, some facts came to our mind. During the discussion, we first were thinking about that this patient seems to be bleeding for most likely an metastatic ATC to the adrenal gland, changing the stage and prognosis of the patient. We were not sure about the efficiency and efficacy of a second interventional radiology attempt to stop the bleeding. And finally, we were, and most importantly, we were not very sure about the availability on the weekend of the service of interventional radiology. So we decided to take this patient to the OR to do an open left adrenalectomy. We found 1.5 liters of blood and active bleeding. And during this time, the patient required 2 additional packed RBCs. The patient thereafter came out to the recovery room with stable vital signs, and the patient didn't require ICU hospitalization, so was discharged on postoperative day 10. The histopathological report of the specimen was consistent with a 2-centimeter metastatic ATC to the left adrenal gland. So some discussion topics, why we decided to jump into surgery. So ICU has limited capacity in our hospital, as it's a very busy service due to the nature and characteristic of the type of patients we treat in our 3rd-level hospital. That makes very complex to get a spot in the ICU for patients with poor prognosis, or patient due to his diagnosis. So watch and wait with only transfusion and evaluations and surveillance of the patients in the ICU is not a very feasible option for us. The same thing happens regarding blood products. As availability is scarce, selective assignment of these products are done in the hospital. In this case, we can say that the patient got lucky to get what he needed. And finally, interventional radiology is not always an available service. We have it commonly during one shift during the week. It is performed mainly by one faculty and is not available on weekends. So in this case, the patient had the second bleeding during the weekend. So as you can imagine, and to summarize, we had to do the best available choice for the well-being of our patient, as you probably would do in any part of North America. Muchas gracias.
Well, thank you, Rafael. So, Professor Solórzano, would you like to comment on it? Yeah. Yes.
Thank you for the privilege to discuss this nicely presented case by Dr. Rafael Perez-Soto. There are several. I'm going to have a couple questions at the end, but just wanted to comment that adrenal hemorrhage has been observed in nearly 2% of autopsy findings, and traditionally it has been associated with sepsis, abdominal surgery, anticoagulants, burns, and pregnancy. With the advent of CT scans, we now find that adrenal hemorrhage is found more incidentally during the time that when we're looking for abdominal pain or flank pain, that we do not expect to find necessarily adrenal hemorrhage. So increasingly, as you saw in this case, endocrine surgeons and perhaps general surgeons, oncologic surgeons are being asked to evaluate these patients with adrenal hemorrhage. I have personally encountered several consultations for adrenal hemorrhage, including primary tumors such as pheochromocytomas, adrenocortical carcinomas, myelolipomas. And of course, this morning we also heard that adrenovenous sampling can also be associated with this. But in those patients, we know that if they come in with abdominal pain, that's what we're going to probably find. In my experience so far, though, all of those patients that I've seen and consulted for have stopped bleeding, even without necessarily intervening with interventional radiology. The adrenal has a rich arterial supply with at least 3 main arterial branches, but there's a lot of connections between these 3 supplying vessels. But interestingly, the adrenal is only drain, or more commonly drain, by a single vein. So this has been described as a vascular dam. So in stress, the body increases the production of ACTH and catecholamines, and this in turn increases blood flow to the adrenal, and perhaps there's increased coagulability also of the vein. And this can lead to rupture of these venules and hemorrhage inside the adrenal gland, and possibly rupture of the adrenal gland. This case brings up several points of discussion that are relevant to the endocrine and adrenal surgeon. The patient presented with pain, and the CT scan showed, perhaps a surprise, that the left adrenal was bleeding and had a hematoma. So point number one, when there's an adrenal hemorrhage, the surgeon should think of a possible cause. You should think of a hidden mass. So the surgeon should, if this stops bleeding, you should follow this to resolution so that you don't miss either a primary or a met or some form of hidden mass. Point number two, the surgeon should also be sure that the other adrenal is functioning okay. Sometimes adrenal hemorrhage is bilateral, and patients may develop adrenal insufficiency. In fact, there are rare reports that adrenal insufficiency can occur even with unilateral adrenal hemorrhage. And point number three, observing patients with adrenal hemorrhage requires a team approach that sometimes we take for granted. In this case, this means that you have to have intensive care units, adequate blood supply, interventional radiologists that are available and able to stop the bleeding, as they attempted in this case, and that interventional radiology can embolize the vessel successfully. So for me, the questions that I have for this particular case, since I imagine you got the PET scan for, I'm not sure if it was pre-op or post-op on the patient with the finding after perhaps pathology, because probably your fine needle aspiration may have been papillary cancer, but then you got a more aggressive tumor on pathology. And perhaps that may have seen, or in retrospect, you saw the adrenal mass. And so if you could comment on that. And then in this patient, there are patients where we have to intervene, where we have to do a surgical procedure to stop the bleeding, like in retroperitoneal bleeds. This particular case, you can maybe describe how you approached it. I would imagine it would be like a zone 2 hematoma. You have to go laterally and mobilize the colon, because this patient had a prior surgery, so it had that complication to it. Thank you.
Yeah. So for the first question, we had a pre-op 18 FGG PET-CT with no evidence of an adrenal metastasis or mass. So that make us think that this developed in 20 days. And the other important thing about having a negative PET-CT is that one of the suspicions is that there could be a field that is bleeding. So we didn't have evidence of a tumor, so we were not thinking about a possible field bleeding into the adrenal. Regarding the second question, we did an open surgery. This patient had a previous cystojejunostomy with a previous acute pancreatitis complication. It was left open. We mobilized the colon. We saw some adhesions. It was a difficult case due to the previous surgery, and when the gland bleeds, it makes the planes, the tissue planes, to get lost, and we struggle a little bit, but we could manage it.
Well, thank you very much, Rafael and Professor Solórzano. So as we said at the beginning, we're going to take any questions from the audience at the end for time restrictions. Our next case is about parathyroid clinical scenario. It will be presented by Dr. Maria Nayvi Espana-Gomez. She is also from Mexico. Now she's living in León, Guanajuato, but is working on that. And our discussant will be our Professor Miguel Herrera, who is well known for all of you as the founder in Mexico of endocrine surgery and mentor of all of us. Please, Nayvi.
Thank you, David. Yes. Okay. Hello, I'm Nayvi España from Mexico City. I am honored to be part of this initiative. I have no conflict of interest. The case I will present is a case of hyperparathyroidism, but not one of these. I will present a case of renal HPT. This is a man that is 33 years old with an end-stage renal disease who has been on peritoneal dialysis for 5 years and was listed for a cadaveric kidney transplant. Patient developed secondary HPT, which was treated with tinacalcet, sevelamer, and vitamin D. But in the last year, the patient presented a pathologic fracture of the right femur, and concomitantly, his levels of PTH and serum calcium rose. As you can see in this chart, the levels of calcium was stable, but the last year it rose. So this happened with the calcium and the PTH. He was referred to the endocrine surgery team, and a subtotal parathyroidectomy was performed without intraoperative complication. A parathyroid remnant equivalent to 1 to 2 normal glands was left in situ, as you can see. The patient developed a severe hungry bone syndrome, requiring IV calcium infusion for 16 days. As an additional complication, he developed a severe infection of the venipuncture site with bacteremia due to Acinetobacter that require drainage and antibiotics. He was finally discharged on the 37th postoperative day. In the chart, you can see the unstable levels of serum calcium until it was normal. It's our feeling that in our community, patients with renal HPT are referred for surgical treatment very late, which makes the operation and recovery more difficult, and it happened in this case. In order to improve the postoperative outcomes of these patients and motivate nephrologists to refer them earlier, 2 strategies have been implemented. One was the administration of calcitriol and calcium 48 hours before surgery and the resection of 3 complete parathyroid glands and a fragment of the fold, in order to leave a remnant close to the size of 3 normal parathyroids, and even in patients with small glands, a complete gland is preserved. With this maneuver, in our early experience, a reduction in hospital stay from an average of 7 to 8 days to 4 days was being observed. And considering that it's generally easy to manage this mild HPT, that it is generally easy to manage that severe hypocalcemia, and that patients will undergo a kidney transplant. So in this occurrence, the HPT will be controlled and the complications may not occur. Thank you. Gracias.
Thank you very much, Nayvi. Professor Herrera, would you like to comment on the case?
Sure. Well, I think with this case, Dr. España illustrates a problem that surgeons from most Latin American countries commonly face: late referral of patients with renal HPT to surgery, which leads to a higher incidence of severe and prolonged postoperative hypoparathyroidism, and this frightens the nephrologist to refer patients to surgery in an early stage. So it's like the hen and egg story. Dr. España has presented 2 strategies to reduce the severity of hypocalcemia due to hungry bone syndrome. and consequently the hospital stay. One is to start calcitrol and calcium before surgery, and the other to leave more parothyroid tissue in the neck. The recommended amount of parothyroid tissue that needs to be left behind in subtotal parothyroidectomy goes from 1 to 3 times a normal gland size, or a remnant weighing from 30 to 80 milligrams. And although there is not much information regarding the outcomes with different remnant sizes, as we may expect, smaller amounts of tissue are associated to a higher degree of hypopara and larger amount of tissues to a higher degree of recurrent or persistent HPT. It is interesting to hear that you have left behind a whole gland in some patients. Although infrequently, smaller hyperplastic glands may be encountered intraoperatively. It is unclear if leaving an intact gland in those patients is an equivalent alternative. In patients with primary hyperplasia, similar results have been reported leaving a small intact gland than a partial gland. You may be able to tell us the long-term outcomes on your renal patients. Dr. Espana has shown that with her approach, hospital stay due to hungry bone requiring IV calcium has been reduced. The usage of this strategy in patients undergoing kidney transplant may be appropriate, since the transplant may reduce the risks of persistent or recurrent HPT, leading to complications or the need to surgical reintervention. I encourage you to keep track on your patients. We will be very interested in knowing your final results. And I am sure that Dr. Carmen Solórzano will be very happy to comment on this case.
Well,
No, I think
thank you very much, Nayvi, and thank you, Professor Herrera.
Is this working? I would like to invite Evandro Vasconcelos from Brazil to present our thyroid case.
We can ask the audience to make comments, don't you think?
Well, I mean, that was being the expert. Comment first.
Good afternoon. My name is Evandro Vasconcelos. I'm an endocrine surgeon in Curitiba, Brazil. At first, I'd like to thank AES and the co-chairs of the task force for this kind of invitation. To me, it's an honor and a privilege to stand in this podium. My task today is to present how to manage a suspicious thyroid nodule into the Brazilian reality. So, the case is a 42-year-old, I'm sorry for this problem with the image. It's a 42-year-old male. There's an attorney at law presenting with an incidentally found 15-millimeter nodule, solid, hypoechogenic, wider than tall, located in the right lobe of the thyroid. This is the nodule. As you can see here, no pointer available, sorry. So this is the nodule. There are irregular margins and no microcalcifications are evident. And the nodule is also located close to the tracheal wall with a connection with an almost right angle to the trachea. So either if you look at the ATA or the T-RADS ultrasonographic features, this is an intermediate to high suspicion nodule. So it underwent an FNA that came Bethesda 3, and some atypia was found. This FNA was repeated within 90 days, and a Bethesda 1 result came due to paucity of cells. This patient had no history of neck radiation, Neither there was a history of familial history for thyroid carcinoma. So what would be the next step? There we see the different realities. Let's assume that this patient were in the United States. To make a molecular test on this nodule would be a probable situation, because in the United States, molecular tests are widely available, and there are many viable options that are accredited by the American College of Pathologists at an affordable, let's say, an affordable cost. And it must be considered as a possible decision too. Conversely, in Brazil, molecular tests are available, but with many restrictions. The most important of them are that these tests for us are very expensive, as we are a middle-income country, and the options available, only one of them are ACP accredited, and for sure is the more expensive one. And when we consider that over 70% of our patients are only covered by the public health system, where molecular tests are not available at all, and even the patients that are covered by a private health insurance will not be reimbursed for this test, it's always going to be a patient out-of-pocket situation. So what you got to do? We got to work with our resources. So we must squeeze all the juice from this lemon. So we provide the patient a higher degree evaluation. So this patient would be reevaluated, been submitted again by an ultrasound, by a thyroid dedicated radiologist. The slides will be reviewed by a specialized pathologist, and from the clinical standpoint, the size of the nodule will always matters a lot. Some clinical observation about the nodule progression, if there is going to be a lot of weight too, and all the management options will be on the table, since the most conservative to the more interventionist. And the patient preference is always been taken on account. This paper was published by our local endocrinology and radiology group, and it shows how we deal with these Bethesda 3 and 4 nodules using the ultrasound in a more deep fashion. And it shows us that in these Bethesda 3 nodules, if they are not that suspicious, if they're of low suspicious in the ultrasound, the incidence rate of malignancy in the final pathology report is below 10%. On the other hand, the same Bethesda 3 nodule, if they look suspicious in T-rods or in the ATA classification for suspicious of malignancy, it's around 50% of malignancy in the final pathology. So the results shows that both ATA and T-rods were effective in these Bethesda 3 nodules to rule out malignancy with a negative predictive value of above 94%. That is similar to what is seen in other settings where molecular tests were used. This is a paper from Israel that shows how unlikely a Bethesda 3 FNA it is to be higher in a higher degree than the low-risk cancer. Some questions must be asked when we are dealing with such a nodule. Is it still safe to observe for some time this nodule? Or is there any other reason that demands immediate intervention? If a rescue operation is eventually needed, would the risk be increased by the observation? And when we consider to ask the patient to pay for a molecular test, we have to think about how much value is actually added when we do this test. And this decision path just shows us different realities. Let's think that this patient is now in the United States, and let's assume that the molecular test was performed. This is an approach that is supported by the guidelines, and we believe that is done to increase the safety of care. And we also assume that it's cost-effective. And I think the main objective here, if we have a positive test, is to provide the patient a safe one-step surgery to solve the problem. And if this test is negative, the patient is safely counseled to avoid surgery and to be kept in observation. But the patient went back to Brazil, and the molecular test was not performed. It was not performed because of the available resources we had, and we had to deal with it only with this clinical guidance. There are also guidelines supported and that have similar results to the molecular test approach. In our environment, unfortunately, molecular tests may be not cost-effective, and observation, in some cases, are going to be always an option. I'd like to thank and congratulate AES for this initiative, and I believe strongly that trying to understand the reality of the other one is the best way to build bridges. Thank you very much for your attention.
Dr. Shaha.
Thank you very much, Evandro, for that interesting case. This is the common cases. This is the kind of case we see commonly here. 10, 15 years back, we never had arguments. You know, I use my hands, ultrasound, 70% success. I can tell the patient, you've got 80% chance of cancer. Now we do the molecular testing, and my accuracy has gone down. Now I tell them there is a 40% chance of cancer because I don't use my hands, I don't use my ultrasound, I don't use my brain, because we are now technology dependent. Now the case he presented is interesting. Is attorney at law. Every time you present a case about thyroid, it's either a politician, a senator, or attorney. So the panelists become very confused. I don't know what exactly to do. The easiest answer for this patient, you need surgery. You'll never go wrong. What is the chance he has cancer? The most important finding in his ultrasound is irregular margin. That puts me into high risk of cancer, and he already defined that. The high risk of cancer, and he showed the data about 60 to 70% chance of cancer. Keep in mind, even today, the thyroid evaluation is a clinical judgment. It's our judgment, and there is a triangle. The judgment by the physician, the patient, and the investigation. This triangle has to be complete. If the patient wants surgery because he is very worried, if somebody has told him you may have cancer, go ahead and operate on the patient. You are not going to go wrong with that. He does not need total thyroidectomy. Even if he is BRAF positive, I would not do a total thyroidectomy on him. The only time I will have some concern, he is BRAF and TERT positive, and he is not TERT positive because it's a small nodule. The TERT positive patients are really very aggressive, older patients, larger tumor. That's my personal feeling. One of the important aspects about this case is you need to tell the patient there is a good chance you have small cancer, but you have been living with this for last maybe 10 years, 15 years. We don't have old ultrasound. I'll be happy to follow you, see you in 6 months, and then operate on you. But at that time, if we find the cancer, don't get upset with me or yourself, because we know there is a good chance you have cancer. You want perfect answer, black and white, I'll do it. The difference in the needle biopsy in thyroid, it is never black and white. It is white and gray. That's the problem we have in thyroid. And the patient need to understand that if it is gray, it's a low-risk cancer. And again, I think we need to be very careful when we talk to the patients. And the last thing I want to say is, there is nothing wrong in telling the patient, you may have thyroid nodule for some time, I'll be happy to see you in 6 months, redecide. The risk of complications do need to go in the discussion with the patient. The final decision should be made by the surgeon in the operating room. You find 10 positive nodes, I'm going to do total thyroidectomy. Patient needs to become a part of the decision maker. And the last thing I always want to say, the cost of these tests, prohibitively expensive tests. Luckily in the United States, most of the time the insurance covers, but that's not the story in 80% of the world population. They manage the patients very well clinically with good ultrasound. The cost always goes in the discussion. Yesterday we heard a fantastic presidential address from our dear president. He talked about financial toxicity. But remember, Mr. President, 80% of the people have forgotten 80% of what you said 80 minutes after your talk. So everybody has forgotten what you said, and now you are going to get toxic with that financial toxicity. So just be aware about this. Again, I just want to say that this patient can be managed anyway. I'm worried about it because it's an irregular nodule. To me, that is the most important finding. And I would definitely offer him surgery. It is a small cancer, you're done. It is benign. He's 42. Think about any thyroid nodule from 42 to 92. Can we leave him alone for next 50 years? Probably not. Can we observe him for a year, 2 years, 3 years? Probably yes. That's my judgment on this case. Thank you very much.
We would like to open the session to the audience. If you have any comments, you would like to say anything, we would like to hear from you.
So hard to see.
No one. Too much taco and tres leches, is that what that is? Mr. President?
Yeah, it could be too much food. That's certainly the case. Maybe I'll start out. I think that this is an excellent point and about the sonographic features, and I think that we're talking about providing care in areas that don't necessarily have access to things like molecular diagnostics. But we always have access to the physical exam and a good history. And those things also are very important in my practice. And, you know, findings of, for example, fixation of a mass to the underlying trachea, that takes almost all the guesswork away. Or findings of hoarseness or ipsilateral vocal cord immobility. So I think all of those things certainly play a role in pulling the trigger for surgery, knowing what you're dealing with. And I just wanted to bring it up because it wasn't something that we necessarily highlighted before. But I see some people coming to the microphone, so I think I'll end with that.
Yes, Dr. Superstein, go ahead.
Hi, Alan Silverstein, Cleveland, no conflicts. One of the interesting tricks on that last case that I was concerned about was the proximity of that lesion to the trachea. And obviously, if it grows, it could invade the trachea, and you want to operate sooner. One of the tricks I do in my office is I do graded compression of the transducer and actually show that the lesion can move separately from the trachea, and that at least tells me at that point it's not fixed. But I'm still concerned because it's close.
I just want to say, don't be shy to get a CAT scan. Not because it is going to change much, but as a clinician or as a surgeon, we get better idea. We get a three-dimensional view of the thyroid nodule. The irregularity also helps you to look at the paratracheal lymph nodes, which may be difficult for average sonographer. I know Carmen can do that, but I don't think many other sonographers are so good with that. So don't be shy about getting a CAT scan. The whole philosophy that the dye will delay the radioactive iodine has very little meaning. Nobody gets RAI within 1 month or 2 months after surgery. It takes 3 months. It takes 6 months to get appointment with the endocrinologist. So just forget about getting the RAI so quick. And that's why the third edition of the ATA guidelines did endorse CT scan with contrast. Anytime there is a suspicion of the features that Cord described, or clinically palpable mass, or nodes, I would get a CAT scan. For me, it is a good investigation.
We have.
Hi, Tom Fahey from New York. First, I'd like to congratulate Cord on doing a tremendous job at taking this initiative to the next level. He really has done a great job, and thank you for all the panelists and, from all over. It's really delightful to see this. I have a question about ultrasound availability for the surgeon in Latin America. How often is there an ultrasound available in the office? Is that something that only the radiologists have, or is that something that you do have access to as endocrine surgeons?
I mean, to get access is kind of easy. For example, in the public hospital, we have an ultrasound in our office. The problem is in private practice, because as a surgeon, you cannot give a report of the ultrasound. So if you cannot give the report of the ultrasound, the cost of the ultrasound is going to be only on you. You will not get reimbursement for that. So that's what many surgeons do not invest in an ultrasound. But I think that the new generations are more used to use the ultrasound as a part of the physical exam. And now many endocrinologists and surgeons are having an ultrasound at their offices. But in terms of how general is this, is very irregular. I would say, at least in Mexico, in the big cities, some endocrinologists and surgeons do have ultrasound, whereas in smaller places they do not.
Maybe Evandro, you can share the Brazilian reality.
I can share I'm going to turn this way. It's a great question. And I can tell you from the Brazilian standpoint too that this is not very homogeneous, but as we should talk about the public health system. And the Brazilian public health system is organized in the primary care, secondary care, and tertiary care. In the primary care, ultrasound is already accessible to the patients, not in every office, but as long as a patient has a nodule that's detected on palpation, for example, it goes to secondary care, and if it needs surgery, it goes to tertiary care. So if it's a suspicious nodule that's been suspicious in FNA, it certainly goes to tertiary care centers. So in the tertiary care center, as we had there, both in endocrinology offices as in the surgeon offices, we have people that can do ultrasound, and there is ultrasound available in the biggest centers.
Thank you. Jorge?
Thank you.
Dr. Herrera, first I would like to say thanks for everything that you have done in Mexico for endocrine surgery. And second, in Mexico we have several realities in medicine. Currently I work mainly in private practice, and we can do state-of-the-art surgery with robots and with all the technology, but that's just for a few 5% or less patients that have a health insurance, and probably another 5% that have the money out of the pocket. The other is the institutional medicine that has state-of-the-art top facility hospital like the Nutrition Hospital, my alma mater, and the rest of the public health. And there is like the sandwich in between, that there is hospitals in small towns or in large towns that are low cost, where you can do surgery. The way that I try to contribute to society is that I travel to a town that is next to Guadalajara, where I am, and we do a lot of thyroid surgery in there that is paid the hospital, the cost is really low, by all the migrants that are working here for you, and they send money and they pay for their relatives for the hospital costs. And another way that I have tried to figure out for my patients how to avoid that financial toxicity has been trying to do ambulatory surgery. That reduces a lot the costs, as long as also I've seen the complications. So, well, that's our Latin America reality. As you were saying, if we do a molecular testing, with the cost of the molecular testing, we can pay the surgery for that thyroid nodule, and you still have money for something else.
I was going to ask, with the access to ultrasound, nowadays we have miniaturized ultrasounds that cost $2,000, which are, compared to the ones that I've had when I started, which were $35,000, $40,000, $45,000. I wonder if that's being utilized to a greater degree in these areas where, you can't report it out and necessarily get back the money that you spent, but this is a much lower investment. Are people using point-of-care ultrasounds, the very small ones, in their practices in Latin America? Yes? No? Saw some heads wave.
Point-of-care.
You do? Yeah? Yeah?
I have a question about, there's
Capel.
We have Capel.
Hey, yeah,
Keppel?
quick question. Just to change the topic a little bit, I mean, we have an identity crisis, obviously, here in the United States when it comes to endocrine surgery and patient access, and we heard a lot about that earlier today. How does it work in Latin America? If you have a patient who has a thyroid nodule or hyperparathyroidism, the referral practices, the concept of an endocrine surgeon, how does different parts of Latin America, South America, what's the identity of the endocrine surgeon?
What's the identity?
Well, unfortunately, there is no identity for endocrine surgery. For example, in Mexico, I will be talking on this tomorrow. In Mexico, there is only one institution that trains endocrine surgeons. So it's going to take 50 years to have a good group of endocrine surgeons in our country. In most Latin American countries, thyroid surgery is performed by surgical oncologists or by general surgeons. Adrenal surgery by surgical oncologists or by urologists. So in parathyroid surgery, mainly by, again, surgical oncologists or endocrine surgeons. So I think it's going to take a while to have a good group of endocrine surgeons in Latin America. And I think that generalizes for all the countries. I was talking yesterday with our friends from Brazil, and they say that in Brazil is the same thing because there is not a specialty called endocrine surgery that can be board certified, and therefore you cannot advertise yourself as an endocrine surgeon.
Do we have more comments?
I have a question about the conduct of parathyroid surgery in Latin America and whether or not, at least in secondary hyperparathyroidism, what do you use for localization, if any, imaging study? And do you use intraoperative parathyroid hormone monitoring? Do you use frozen sections? How do you, keeping the patient for that many days in the hospital, it's a big expense for these secondary patients, so I can see how there's the renal doctors don't want to send you these patients because they're going to be in the hospital for a long time, but yet again, it's kind of like a continuous issue because they're waiting too long, and then, so I would like to hear those comments or your.
Well, for example, for the localization for primary HPT, we use gamma and ultrasound, but sometimes those are negative both. So the patients went to surgery to bilateral neck exploration, and we don't use intraoperative PTH because we can avoid this, yes. So the only thing that we do is to go to the laboratory person and say if they can process it quickly, the PTH, but it's about 20 minutes. It's the less that they late, but is the problem. So this kind of long stay, hospital stay, it's very cost to the patients. And in the public hospitals, this can be happen because the patient don't pay anything. But the private practice of with people in rural sites, it's so difficult. This is the purpose of these kind of maneuvers that I exposed you today, because it's more easy to us to have a following of the patient with maybe not too low calcium, maybe not too low PTH, but sufficient to be fine with no pain, no bone pain or something. That it's more cheap and easy to follow them that with a patient that don't have the money to pay a very long hospitalization. Yes.
Thank you, Nayvi. We have time for maybe one or two questions.
Michael Starks, Bangor, just wondering, I've operated in 3 other countries outside the U.S. on short-term surgical trips. I don't think I've ever done a total thyroidectomy outside of the country because of the concern for availability of thyroid hormone. In some of these places, they couldn't get a TSH done at their facility. I'm just wondering, I'm sure the answer is pretty variable, but what are the things that people can't get in smaller locations, and how are you guys dealing with those? And are there ways that AES could lobby for you to help with those things?
Do you want to answer?
I didn't understand what was his question.
You don't know.
Is availability of
What things you can get
TSH and thyroid.
We're having a hard time
We could
to hear
have-
what
we could
comes
have
from
each
their
of
mic.
our-
Yeah, I'm sorry, I couldn't hear.
Do you want to have each of the presenters just, yeah, go ahead.
I couldn't hear.
So, I can answer you, Mike. Thank you for the question.
Should be the last question.
Thyroid lab tests like TSH or free T4 are, plenty available to the whole population in the public health system, as it is levothyroxine. Population get it for free, for life. Everyone that needs it. So it's not a concern, despite the morbidity of surgery, to do a total thyroidectomy, because they have it for free from taxpayer money. No.
I think Rafael,
We would like to thank everyone for participating of this session. We are very happy that this happened and have all of you here to ask questions and listen to what our presenters and our discussants have to say, and I really appreciate your participation. Thank you so much.